So we are currently on YouTube Live. I'm just going to give it a couple minutes so everybody can start and join, and then I'll get started. All right. Hello, guys, and welcome. Today we have Dr. Amanda Shi, who specializes in anesthesiology, and she's going to be presenting with us today. So welcome.
Thank you guys for having me. I'm really excited to be able to share in my specialty as well as my subspecialty, which is critical care medicine. So we will be able to go over a little of my background as well as go over a case in which I'm actually going to have a little fun with it, and we'll take you through how it looks in the operating room as well as into even the ICU, so you can see some of what my work looks like. But before we delve into that, I wanted to tell you guys a little bit about myself. I know that this organization at least has people based in Michigan, and I am from Michigan, so it is the best state ever. I'm originally from Metro Detroit. I am currently living in Boston, though. I had an interesting backstory. I decided that I was sick of high school pretty early on and applied to an early college after my sophomore year, and actually dropped out of high school and went to college early. So I went to Western Massachusetts at Bard College at Simon's Rock for 2 years, and then transferred back to the University of Michigan in Ann Arbor to finish my bachelor's and master's in biomedical engineering. Another thing that I did that was kind of off the beaten path was that I decided to be part of the charter class at Oakland University William Beaumont School of Medicine. And it's also that at least a couple of you guys may already know from Michigan that it's a brand new medical school in Michigan, not Oakland, California, not Beaumont, Texas. And so that's that. But I went to brand new medical school, and then after medical school, I matched at Henry Ford Hospital in Detroit for my internship, which was a transitional year, and then Mass General for my anesthesia residency. I also did fellowship here at Mass General and have stayed on as an attending anesthesiologist and intensivist here at Mass General in Boston. So, easy question, right? What do we do? This seems like a really obvious thing, but our society, the American Society of Anesthesiologists, defines our job or specialty as individuals who evaluate, monitor, and supervise patient care before, during, and after surgery. We deliver anesthesia, and we also lead a care team model so that we can optimize patient safety. We also do other subspecialty work, including pain management and critical care medicine, and we'll delve a little more into subspecialties within anesthesia as well. I did want to highlight here what this anesthesia care team means. It means that as an anesthesiologist, I work with nurse anesthetists or CRNAs. I work with residents, so anesthesia residents that are training to become anesthesiologists. And I work with, well, I personally don't, but some anesthesiologists work with anesthesia assistants. So altogether, we care for patients in the operating room and provide their anesthesia. Typically, the model is that the anesthesiologist supervises a number of these individuals, and we kind of go from there. So what do critical care anesthesiologists do? And I do want to say I appreciate all of your questions. I'm going to answer all of them at the end so that I'll just go in order. So keep them coming, but I'm going to keep going with my presentation. In terms of critical care anesthesia, what we do is we supervise, coordinate, and manage a patient's care in the ICU with the team and work closely with our surgical colleagues as well as other subspecialties in order to care for our patients. What this really translates into is I was surprised actually when I explained to someone that I was also an ICU doctor because I'm an anesthesiologist, and someone had asked, oh, so do you provide anesthesia in the ICU? And I was like, no. I'm actually the ICU doctor. That means that I oversee the care of the patients in the ICU. And so I just wanted to make that distinction and make it clear that I wear two hats in the hospital. I can be an anesthesiologist in the operating room one day, and I can be the ICU doctor in the ICU the next day. And so I think it's important to consider. Something else that I feel like is important to at least mention is that, in different specialties, there are discrepancies in the genders. And what we find in anesthesia is that it's still pretty male dominated. This is about 40% women across the country. That data hasn't really been updated, but I think it's interesting because anesthesia is actually a pretty flexible specialty and we have a relatively good work-life balance. And so as a result, I do think it's a great specialty for women, but I also recognize that there are certain things about the environment of working in the operating room that are not optimal. So how do you become an anesthesiologist? Well, I kind of alluded to it with my background. You go through college, you get your degree, you go to medical school that can take 4 years, or if you do MD, PhD, it can take longer. And then you do 4 years of anesthesia residency. So what happens with our anesthesia residencies is they're kind of split up differently. So what happens with anesthesia is that there's one kind of residency where you do internships separately, and there's another kind of residency where you do it all combined in one place. So at Mass General, many years ago now, or 5 years ago now, what happened was we had a program that was split up. So most of us had to do internships somewhere else and then moved here for 3 years of anesthesia training. Now our program is all 4 years in one place. Those program types are called advanced versus categorical. That's only important once you get into medical school and have to decide on a specialty. There's certain specialties where there's only advanced spots. So I did that. I also really wanted to be able to stay close to home for internship, and I saved a ton of money by staying in Michigan for internship, and also got great experience at Henry Ford because I was able to serve an underserved population, which I don't do as much now, and that's a lot more gratifying of work. Also, You can do fellowship as an anesthesiologist. All of our fellowships are only 1 year long, which contrasts to internal medicine fellowships. So people who want to be a cardiologist or a gastroenterologist, they have to do 3 years of fellowship. Our fellowships are only 1 year long. So it's really easy to go ahead and just tack on an additional subspecialty. So anesthesiologists can subspecialize in a lot of different areas. This is not an exhaustive list, but it's a list of a number of areas in which we can do extra training in. Cardiothoracic anesthesia, when you do fellowship training in that, it's to manage patients that get open heart surgery or any kind of just open chest surgery in general. The fellowship training includes certification or learning how to do transesophageal echo, which is using an ultrasound that goes in the esophagus to look at the heart's function. So that's one of the big reasons that someone would get extra training there. I do critical care anesthesiology. I've already alluded to that. I work in an ICU as well after my 1 year of additional training in the ICU. Neurosurgical anesthesiology is for patients for extra training to be able to care for patients that get any kinds of brain surgeries or things along the neurologic organ system. And what's really important to know is the management frequently of things like high pressure in the brain or high intracranial pressure. Those things are very damaging to brain cells and the brain matter. And so as a result, it's important to get extra training there if you want to manage those patients predominantly. Obstetric anesthesia, I think this is one of my favorite fields. Although I didn't go into it, what I'll say is that this is typically the first encounter many patients have with an anesthesiologist is when a mom is going through labor and needs an epidural. That's typically placed by an anesthesiologist. It's a very rewarding specialty because we actually get to take away patients' pain and we become the heroes in that situation. In terms of pain management, so anesthesiologists get specialized training in pain medications in the operating room because we use them so frequently. And so as a result, we're actually very good at pain management in an operating room setting or outside of the operating room, even outside of surgery. We can get extra training in acute pain, which means in the hospital, if someone's having surgery or something along those lines, we could do things like blocks. That's where we go ahead and put numbing medicine around nerves and specialized areas. We could do that. Or chronic pain actually addresses a lot of patients' pain who have like chronic low back pain outside of the hospital, where we can do procedures in order to help address that pain as well. And finally, I like to mention that we also can specialize in palliative care just because of our knowledge and comfort level with managing opioids and other pain medicines. It lends itself really well to the fields of palliative care as well. Now, I'm sure all of you guys are wondering what my typical day is like. So in the operating room, I will say that every hospital is very different in the way they manage things. There's surgical centers that do hours a little differently. There's different practices that do things a little differently. But in my particular practice, my typical day is from 7 a.m. to 5 p.m. What this means for me is that I get to the hospital usually before 7 a.m. to just make sure I tidy up on other things. If I'm doing my own room, that means I'm providing the anesthesia to the patient myself. Then I usually get there a little earlier because I like to set everything up and get everything ready for the patients. If I am supervising, so I personally work with nurse anesthetists and residents, then they're the ones typically setting up the room and I can get there a little closer to 7 rather than earlier. That being said, I change into scrubs when I get to work. I go into the pre-op area by 7 a.m. and I start to meet my patients. So in our state, we have to, at least in our hospital, we have to get a separate form for anesthesia consent. So I go and meet all the patients. I introduce myself, I answer my questions. If our nurse anesthetist or resident hasn't seen the patient yet, then I'll go ahead and do all of the talking about how the anesthesia is going to go, do the consents, and then sometimes I'll place the IV. It just depends on timing. By 8 a.m., our hospital starts our cases. There's other hospitals that will start cases earlier, like 7 a.m., and certain rooms we can get in the room at like 7:30 in the morning. It just really depends. But generally by 8 a.m., we should be starting our cases. We should be going into the operating room before then. That is the time when I will be going from room to room in order to start the anesthesia. So anesthesia is frequently associated or compared, to flying a plane because takeoff and landing are the most critical times. And so that means going to sleep and waking up are some of the most critical times within anesthesia. There isn't an autopilot function on our machine. That's not like when we're asleep that, suddenly we can just sit back and do nothing. However, there's less stuff typically to oversee, especially when we've hit a steady state of our anesthetic and a patient is healthy. If the patient is not healthy, there can be plenty of stuff to have to do throughout that maintenance phase that we have in anesthesia. Now, what you'll see as well on this schedule is that I say 9 a.m., 11 a.m., and 2 p.m., I have to give breaks. So that's a funny thing, right? But what I'll say is that anesthesiologists can't just like walk out of the room when someone is anesthetized. You actually have to be there managing their anesthesia the entire time. So that means you can't walk out to go to the bathroom. You can't walk out to get a cup of coffee or water. You actually have to have someone else come in the room. So if I'm supervising people, I will go in to make sure that they can step out for a specific time frame for a break in the morning, for a specific lunch break, and then an afternoon break. That's our typical standard thing that we'll do. Other things that'll happen during the day is that if I'm in an operating room with a case that's really long, then we may just send a patient off to sleep in the morning and then they're done at like 5 p.m. That can happen. Other times there's cases that are shorter and then we do a lot of them in a room. And in those situations, I may be going into the room and constantly there in order to get patients off to sleep, et cetera, et cetera. So by 5 p.m. though, that's when my shift is typically done. One of the reasons why anesthesiology is a really good work-life balance specialty is because you can always hand off a patient to another anesthesiologist. What I'll say is that because I'm at an academic medical center and I personally enjoy caring for very, very sick patients, for patients that have a lot of comorbid diseases. And I like to care for patients undergoing really, really big surgeries. I typically don't hand off my patients when I'm caring for someone that is sick or undergoing a big surgery. So for example, last Friday, I cared for someone who underwent a 12-hour surgery and I left the hospital after midnight and I had started in the hospital at 6 a.m. And that's because of just a professional courtesy on my end. I think it's really important from a patient safety standpoint too, because if you hand a patient off to someone else, you're inevitably going to miss things and you're going to forget to mention things. So it's important, I think, in those circumstances to stay with the patient and finish it out. In other circumstances, when someone is really healthy or the case is a very small case and the anesthetic is not very complex, then I feel like it's fine to go ahead and pass it off, because at the end of the day, we're not going to add a ton more just because I'm staying around. So by 5 p.m., someone else can come and get me out typically. Now, the other thing to be aware of is my ICU schedule. I like to mention this as well. It also is 7 a.m. to 5 p.m. However, it's structured kind of differently. So I'll get in at 7 a.m., I'll get my scrubs, and that's when I get a sign out, or I learn about what happened with all the patients overnight from the attending that was working overnight. And then at 8:30, I start rounds. If you guys have done any shadowing or kind of like seen on television, rounds are typically when we go over each patient. We have a presentation for each of them as a team and then come up with the plan for the day. So in the ICU, our team is typically me as the attending. I'll have a fellow, I have a resident, I have nurse practitioners. We have a pharmacist, an ICU pharmacist that will run with us, and then we have the nurse that's caring for the patient. What we do is we do a very detailed presentation of what's going on with the patient and go over all their medications and our plan for what we're doing for the day to advance their care. Now, we do that for every single patient we have within the ICU that we're caring for. That can take a number of hours. And on top of that, we're a teaching institution, so it takes some time to be able to teach the residents or teach some of the nurses when they have questions about things that we're seeing in the ICU. I'm typically done with rounds by around 11 a.m.-ish. It depends how busy it is. However, there's another special thing in my particular ICU that we do, and that's carry the airway pager. So because I'm an anesthesiologist, I'm an expert in intubating patients. And as a result, we actually carry a pager that in the hospital, if someone is in respiratory distress or having trouble breathing, that we get called to look at them and decide, hey, does this patient actually need to be intubated and go to an ICU, or is there another intervention we can do in order to get them better or get their breathing better? And so that can go off at any time. And if it does, we actually just stop rounds, walk out and go check up on the patient and take care of that patient rather than stay in the unit. So that's something that can happen at any time, 24 hours a day. After we're done with rounds, we typically are going to go back and do procedures. So we'll do things like central lines, we'll do chest tubes, if we need to intubate someone in the unit, if it's not urgent, other things that we need to take care of, phone calls, consults, all these other things will happen after rounds. And then in the afternoon before 5 p.m., I will walk back around, assuming I'm not already there because we have new patients coming in or other things happening. And I will find out what's going on with everyone, get updates, and then sign out to the overnight attending at 5 p.m. Now, it's important to recognize that we have to take calls. So my life is much better. My work-life balance is much better now that I'm an attending. So when I was a resident as an intern, I did 36-hour call. As an anesthesia resident, I did 24-hour call. Now I just do overnights. And there are some attending practices where you do 24 hours in the hospital, but sometimes you get to nap, sometimes you don't. It just depends on the setup. But just be aware, in our specialty, typically, if you are an anesthesiologist in a hospital that can do surgery 24 hours a day, that means that you need an anesthesiologist in the hospital for 24 hours a day, 7 days a week, 365 days a year. So we do have to work holidays, weekends, nights, things like that in order to ensure that we can care for our patients. However, not every night do we do surgeries or emergency surgery, so it's sometimes possible to be able to take a nap, but yeah, it depends. Okay. I wanted to give you guys, because it's really challenging actually to shadow an anesthesiologist, because most of what we do is not that exciting looking. I mean, we do some procedures, we send someone off to sleep, we put in a breathing tube, and then suddenly it looks like we're doing nothing. So I wanted to be able to share with you guys, I want to teach you guys about the types of anesthesia, so you can think about what I'm thinking of when I'm assessing a patient on what kind of anesthesia they'll get depending on the surgery and other things. Now, the most common type of anesthesia people think of is general anesthesia. And general anesthesia is when you go completely to sleep. So what you see here is that that's a mask over there. What's funny about this is a lot of my patients say, oh, is the medicine in the mask? And I'm like, no, unless you're a baby, typically the medicine is not in the mask. Typically the mask just has oxygen, and we use the IV to send people off to sleep with our anesthetic. There are times kids, what they do is we can actually put gas on in the mask, and kids will go to sleep breathing the anesthesia gases. But typically we don't do that for adults because we can run into some issues with that. We like to use the IV for that. It's a lot more controlled. So that's just something to be aware of. Now, under general anesthesia, typically we have to hook someone up to the ventilator, either to administer our anesthesia gases or to be able to breathe for the patient, because we give them medication to relax their muscles, a muscle relaxant, so that it helps with surgery. So typically we will use something called an endotracheal tube in order to connect a patient to the ventilator. The endotracheal tube, as you can hear from the word, sits in the trachea, and it's placed using a procedure called intubation. So now with COVID, more and more people have heard of this, intubation, meaning putting a breathing tube in, but it's something that we do day in, day out, and it's something we're very good at. And we do it typically with a metal blade. So you'll see in the picture on the right that someone is holding a metal blade in their hand and putting the tube in. That's because we use the blade to move the tongue out of the way and then see the vocal cords to put the breathing tube in. Another breathing device that we can use is a laryngeal mask airway. So this is something that actually looks like a little mask, and it sits in the back of the throat. It does not go into their trachea. It doesn't go any further than the back of the mouth. And typically with this particular type of device, many patients are usually breathing on their own, but we can also help them breathe with the ventilator. It just depends on the type of surgery and the type of situation and the type of patient if we decide to use this type of device. Monitored anesthesia care, I usually associate with sedation. So with monitored anesthesia care, that's typically done for patients getting smaller procedures where they can use numbing medicine, things like that, but where we would potentially need to send someone off to sleep completely, like general anesthesia. So in order to do monitored anesthesia care, another common time we do monitored anesthesia care is actually colonoscopies. People will hear about getting propofol and they get a monitored anesthetic care, but in reality, they're like completely asleep. So at the end of the day, with monitored anesthesia care, or MAC anesthesia as we call it, typically a patient is breathing on their own without any airway devices. Sometimes we'll assist them a little. We'll put an oral airway, which is like a plastic device that goes in the mouth, and help them breathe a little. But typically, these patients are not hooked up to the ventilator. They're breathing on their own, and they should be able to wake up pretty quickly from that. Another thing people don't think about are spinals and epidurals as a type of anesthetic you can use with monitored anesthesia care or general anesthetic. Usually it's the monitored anesthesia care part. But the big thing is we actually very, very commonly use a spinal for our joint replacement. So our older patients, we get a knee replacement, hip replacement, they can get that done under spinal. So we place a needle into the intrathecal space. We put a little bit of numbing medicine in there or local anesthesia, and then it causes numbness to go down from the toes all the way up, usually to the abdomen, and it allows for them to do surgery without completely sending someone to sleep. So that's kind of a cool approach. And epidurals are commonly used in obstetrics. So laboring mothers, they get an epidural placed by us, and it allows for a numbness band so that they don't feel their labor contractions. So another really important part of our practice as anesthesiologists are our monitors. So what we are experts in are managing vital signs. So this is one of the most important things in our practice, is making sure that someone's EKG is appropriate, that their blood pressure is in normal range, and that they're breathing appropriately, that they have good oxygenation. And in order to do some vital signs monitoring, sometimes we have to do procedures. So procedures can include things like an arterial line. So an arterial line is a special kind of catheter that goes into an artery instead of a vein. So if you're feeling your pulse over here in the radial artery, that's a very common place that we can place one of these catheters. And what it allows us to do is get a blood pressure every single time the heart squeezes. So it's very important for us, for certain patients that are very sick, that we keep an eye on their blood pressure every single beat of their heart. It also allows us to send labs very easily as well without having to poke a patient with a needle again. Another type of procedure we'll do is a central line. So a central line is typically basically like a really, really long, big IV or intravenous line, but it is one that can stay in place much longer and allows for us to administer specific kinds of medications that should not go through a regular IV that's over here in the anticube. Now, the reason why there's special medications that shouldn't go through a vein over here is because these veins can blow or infiltrate. That means that the catheter goes outside of the vein and the medications get administered into the subcutaneous space, into your skin. And certain medications, if they're administered into your skin, can actually cause your skin to break down and the skin cells to die. So it causes necrosis. And that's why we need to do a central line sometimes to be able to administer some of these medications through it. One of the cool things about my specialty is that we get really good at pharmacology. We're very comfortable with using many different kinds of medications. We're also really comfortable with drawing them up and administering them ourselves. We get good at doses. We get good at pharmacology. Okay, so since we are going to do shadowing today, I thought it'd be important to do a case. Now, this case, like I said, will be kind of a nice example of taking you from the operating room to even the ICU where I work. So this is a pretty common thing for us. We'll see in the hospital. We have an elderly patient, a 90-year-old male. He comes in with a right hip fracture because he was falling, or he had fallen after he was trying to walk around at home. What you'll see here is a PMH, which is past medical history, and his past medical history includes hypertension or high blood pressure, moderate aortic stenosis, which we'll talk a little more about. His medications include metoprolol, which is a beta blocker, and lisinopril, which is an ACE inhibitor that also helps with high blood pressure. Every time we care for a patient, we need to examine them as well. So you go ahead and do a physical exam on this patient, and you find that he's a little confused, which is pretty common for our elderly patients because they end up getting delirious in the hospital. Anytime you get older, you're in a place where you don't get good sleep or restorative sleep, you're at high risk for something called delirium. You find that his mucous membrane, meaning like you look at his lips, they're like cracked and very dry. You go ahead and listen to his heart and lungs. In his heart exam, you hear a harsh systolic murmur in the second right intercostal space. And then you look at the lungs and they're clear. And you also examine his right hip, and you find that his right hip seems to be a lot bigger than the left. However, it seems to be soft. So you push on it, you're like, oh, it's kind of soft. So hopefully that's fine. Now you go into the handy dandy electronic medical record and do a chart review. You find that he's been nothing per mouth, or NPO, for 36 hours, which in anesthesia, we typically ask people to be NPO for at least 8 hours from solid foods. He has IV fluids running at 75 cc's or milliliters an hour. He's received oxycodone, which is a type of pain medication, opioid pain medication or narcotic. And you also notice that the hemoglobin has drifted from 14 down to 10. Now, I want you guys to think about, based on the information that I've given you earlier about types of anesthesia and the information I just gave you about this patient, what kind of anesthesia do you think we should give this patient? What I'll do is I'll just wait a moment so you can think about it. If some of you guys want to respond in the chat, you can, but I'll just give you a moment I'll give 1 minute for this, and then we'll keep going on the presentation. Okay, so we're going to keep going with this particular patient because they're going to get a hip replacement, or RAF, which is a fixation of the fracture. Typically what we can do is, like, if someone's getting a normal hip replacement and they're healthy, we can actually do it under spinal and MAC. But this particular patient has a couple of things that make him not such a good candidate. So when we are caring for really sick patients, we frequently will do general anesthesia for them. And what we do in anesthesia is we think about how we're going to do the anesthesia ahead of time. So there's some components of anesthesia that we consider. For example, lines. How are we going to give all of our medications? So in this particular situation, we're going to use a peripheral IV or intravenous line. And then we're also going to place an arterial line because we will get to that. Airway wise, we're going to use an endotracheal tube. Typically what we find is that we call trauma patients, meaning patients who fall and break their bones, or someone who comes in after a car accident. Their ability to move food through their GI tract is actually slowed down frequently. So they're at high risk for something called aspiration, meaning the food in their stomach comes up and goes into their lungs. That could cause you to have really bad lung disease, or ARDS. And so as a result, we try to avoid that. And then induction means, how do we send this patient to sleep? Well, it's very common, these medications that we're using, propofol, which sends people off to sleep, is the type of anesthetic. Phenylephrine is a type of vasopressor. It causes blood pressure to go up because typically things like propofol cause your blood pressure to go down because it causes vasodilation. Rocuronium is a type of muscle relaxant that we very frequently use to help us put in breathing tube or to help the surgeons with their ability to do surgery. Now for this patient, you go ahead and bolus your propofol, meaning you give propofol, and now his blood pressure is 40/20. That's not a good blood pressure. That's a very dangerous blood pressure. So what you end up doing is you give this patient some medications, things like phenylephrine and other kinds of vasopressors, and you decide that you're not going to do this case because something really terrible has happened. He's almost died after you gave some propofol. Probably not a good idea to go ahead and proceed. So you cancel the case and you take the patient to the ICU on high-dose vasopressors. So again, vasopressors are those medicines that increase your blood pressure, and they're actually medications that very commonly are dangerous to put through IVs, depending on the situation, but typically patients need a central line when they're on high-dose vasopressors. Hence, he comes to the ICU and another critical care anesthesiologist accepts him there. Now, what happened? Something that is important to anesthesiologists, or care anesthesiologists, is aortic stenosis. So what is aortic stenosis? So the aortic valve is the last door, or the last valve out from the heart to the rest of the body. And it's very common for older patients to get calcifications there and get a narrowing of the valve. When the valve narrows, it's called stenosis, right? We're not very creative in medicine. When we say a diagnosis, it typically tells you what the diagnosis is. So the aortic valve is narrower. And what happens with that is that the heart is divided into 4 chambers. The atria are up top and the ventricles are at the bottom. And the left ventricle is the last thing that squeezes blood out from the heart through the valve and into the aorta. That heart part, that chamber of the heart, the left ventricle, frequently has to work very hard because the aorta is so, the aortic valve is so narrow. So if this is really narrow, it can be dangerous if the blood pressure or if the heart is not able to keep up squeezing through this tiny, tiny space. So as a result, anesthesiologists are very keen on being careful with aortic stenosis. If these patients have low blood pressure, it's nearly impossible to do CPR on them because when you do CPR, you're not able to generate a high enough pressure to get blood through a really, really narrow hole. So it's important never to let these patients code or stop having a pulse. In this particular situation, this patient received some blood because you did notice earlier that the patient's hemoglobin had drifted from 14 to 10. And you also noticed that his hip seemed pretty full. So he's probably bleeding into his hip from his bone fracture. That's a pretty common thing that we'll see anytime someone has fractured or broken a bone is that they actually bleed quite a bit and they need some blood in order to keep their blood pressure at a reasonable level. So this patient gets some blood and over the next couple days was able to come off of that high dose vasopressor, those medications that bring the blood pressure up. However, when he's about to go back to the OR, so what I will say is that older patients that get hip fractures, they actually always get surgical repair because when they did a study comparing if you don't repair it versus if you do repair it, that patients who get a repair actually have better quality of life, probably will live longer because they're not in as much pain, and they're hopefully able to ambulate. But it is a really, it can be very dangerous because a lot of elderly patients are pretty sick, like this guy. Now, on the day he goes to the operating room, he goes into atrial fibrillation. This is another important but very, very common thing that we see in anesthesiology. Well, what is atrial fibrillation? Many of you guys probably know from the Apple iWatch that everyone seems to have nowadays is that it is an irregular rhythm of the heart. And the difference is the atria, again, medical people are not very creative. So the atria is the chamber up top. It fibrillates. So instead of normal squeezing, so normally the atria will squeeze with the electrical activity. The electrical activity goes haywire in atrial fibrillation, and instead of squeeze, it just does this. And blood doesn't flow as well through the chambers of the heart, and the atria are just kind of waving around like that. So that's something to be aware of. What typically happens is as patients age, they're at higher risk for atrial fibrillation just because that conduction system or that electrical system can get older and go a little haywire. So this is a pretty common thing. We find out for our patient that actually he's had a history of atrial fibrillation. So as a result, you decide to go ahead and proceed with surgery. Now this time, you do the same type of lines. You have a peripheral IV and an arterial line. Now again, the arterial line is very important in patients with aortic stenosis or heart disease because it's important to keep their blood pressure at a reasonable level. You go ahead and decide to place that endotracheal tube or that breathing tube, but this time, instead of using propofol, you decide to use a different medication called etomidate. Now, etomidate is another kind of anesthetic medication. It has its own side effects and is not commonly used because of some of those other side effects, but it allows for your blood pressure to remain relatively stable when you use it to send someone off to sleep. So in patients that have a lot of heart problems or things like that, etomidate is a very good medication to use. You also use that phenylephrine, which allows your blood pressure to go up, and rocuronium to get that breathing tube in, and you are able to go ahead and do the repair. So they're able to do their fixation of the hip, and the patient does very well under general anesthesia. Typically what we do is most of our patients, we extubate in the operating room. They usually have to be awake enough to at least follow really basic commands to do extubated in the operating room. They have to be breathing, things like that. So he's extubated in the operating room. He goes back to the ICU just to make sure that he's safe in order to leave the ICU and he has no other issues. Well, I hope that this was a informative and interesting presentation for you guys. Just want to let you guys know I am all over Instagram. I am on a current hiatus. I will be bringing content back soon because I just took oral boards, but I'm on Instagram, Twitter, and I started a YouTube channel. I'd love for you guys to follow along, and obviously I'm happy to answer any questions via some YouTube videos, and I'm going to go ahead and start answering these questions here. Go ahead over here. Okay, I'm going to start from the top on questions. What type of anesthesia do you use at your clinic? What is the schooling required for anesthesiology versus a regular physician practice? So I think I answered many of these questions a little earlier. So in terms of type of anesthesia, I'm in a quaternary care center. So we do every kind of anesthesia. And as I mentioned, general anesthesia, back anesthesia, and spinals and epidurals are all types of anesthesia that we use. In terms of, again, the pathway to become an anesthesiologist versus, if I think the question you might be asking is about schooling for other types of anesthesia providers. So an anesthesiologist like me, I need to finish medical school and residency to become an anesthesiologist. If you are going down the path of becoming a nurse anesthetist, you have to be an ICU nurse for 2 years and then do 3 years of CRNA school to go ahead and be a CRNA. There's also the pathway of becoming a anesthesia assistant, and those AAs, what happens is they do 2 years as a master's degree program, and then they can go ahead and practice anesthesia. Another question. My first question is, do you only monitor patients' conditions during operation, or do you have to take care of them after the operation? So in our setup, or in most places in the US, we have a place called the Post-Anesthesia Care Unit, or the PACU, that is run by anesthesiologists. So after we're done with surgery, they go to that recovery area and they have to meet certain criteria and be safe to be discharged from this area, or they need to be intervened on. So yes, we definitely do oversee the care of these patients after surgery for a short period of time, typically, unless they come to the ICU and they're cared for by a critical care anesthesiologist. Second question is, what are some factors you consider when making a treatment plan? So I'm not sure if you're referring to a treatment plan in terms of the ICU patients or in terms of anesthesia, but that all being said, for anesthesiologists, we consider what types of comorbid diseases, what kinds of history and other problems patients have in order to decide the safest kind of anesthesia for them. In the ICU, it really just depends on what the patient is there for and what issues they have, and that's how we determine the treatment plan for them. Again, the specific type of anesthesia really is the patient dependent if there's certain factors involved. So for example, if someone has had issues with nausea after anesthesia, then we can change the type of anesthesia we provide to them. So gases that people inhale via the ventilator really cause people to be nauseous afterwards. So we can change the anesthesia so that we only do propofol in those situations. But it really just depends on what the patient has going on, what kinds of past medical history they have, and that's how we decide on it. Is working as an anesthesiologist a repetitive job? I love this question. And how is the work-life balance of being an anesthesiologist? So in terms of, is it a repetitive job? I would say that I think every single job gets to be repetitive in some way. Every specialty has some repetition. And at some point you have to realize that it takes a while to be good at clinical care. So there's always something new to learn every single day. Even the anesthesiologists that I know have worked here for 30 years as an attending are constantly learning every day. There's constantly new advancements in medicine and in every specialty. So for example, we had a recent medication that came out, Sugamidex, that has changed the way we practice certain types of things in terms of reversal for our muscle relaxants and such like that. So as more medications come out, it really changes how we do things. So I would argue that there's always something to learn, and that the other big thing is I'm meeting new patients for every case. I'm learning from them. I get to interact with different people. And at the same time, I will say I also get some continuity of care in the ICU because I really love seeing what happens to patients after surgery. And that's another reason why I decided to do ICU as well. In terms of work-life balance, I would say that on the spectrum, I'm not like my best friend dermatologist. I don't work only 3 days a week for 8 hours, like a day. That's like the dream life. She doesn't even take call or work in a hospital. Like, cool, that's awesome. But that's not my interest. I don't love dermatology. But on the other end of the spectrum, I'm definitely not a surgeon. I don't live, breathe, eat OR and surgery. So that's the other kind of level. I'd say that we're a little closer to the dermatologist side than the surgeon side because of the fact that a lot of the administrative headaches that a lot of other specialties have to deal with, we do not do at all. So I will never get a call from a patient in the middle of the night asking for a new prescription. I will not get told that I need to call an insurance company to get approval for patients. I don't have to write notes in a clinic and only see patients for 15 minutes at a time when they really need a half an hour or an hour. So those types of things I don't have to do. And in anesthesia, we have very few notes we have to write. So all the stuff we put in the electronic medical record, we don't really have to do very much. It's all automatic in the operating room for our work. So that's a huge burden I never have to worry about. And I don't take that work home with me. A lot of my colleagues who do primary care specialties or clinic specialties, they have to take their work home with me. Even my dermatologist friend, they go home and do their notes at home, right? And I don't do that. In the ICU, that's a little different. I do a lot more notes. That's why in the ICU, the burnout rate is much higher. So that work-life balance is not as good, but it is still shift work. It's still better. There's still less that I have to do in other places. Because again, my ICU patient's not going to call me up for a prescription or ask for insurance coverage. They need to be there and they need to be cared for. So that makes it a lot better. What type of assessments are done with the patients prior to surgery to decide what type of anesthesia to use? What type of emergency medicine measures can be done when unexpected developments happen during surgery? So let's say about assessments. What we do is we used to have a pre-op clinic where people could come in person, but nowadays with COVID, and actually even before that, we have changed it now where we do a phone interview to ask people about their history, what's going on, give them instructions about not eating and drinking, which medications they're allowed to take or not take before surgery. And then at that point, if a patient has some sort of issue with their medical history, they're not completely healthy, then they will get assessed by an anesthesiologist on the computer to determine if we need things like a stress test to check on the heart, if we need other kinds of labs or things to just look at what's going on in the patient's like kidney function or liver function, things like that, that will impact how we decide on our anesthesia. I'm not sure in terms of emergency measures. I'll say that the types of emergency measures we do is like we'll tell the surgeon if the patient starts needing CPR, if they lose a pulse. We're the ones that are directing, defibrillation, shocking a patient if they need it. We're the ones managing, pushing the epinephrine if someone loses a pulse or an unexpected loss of, or if they need, resuscitation in some way in that way. We're the ones that go ahead and put in those really big IVs and things. So again, I mean, on Friday, I did a really big case where a patient lost their blood volume. So your entire body has typically around 5 liters of blood. They lost 35 liters. So they lost their blood volume 7 times. So I was one of those people that was making sure they got enough blood to stay alive. So those are some of the emergency things that we can do and that we direct anesthesiologists. I talked about some next questions on work-life balance and the route to get in. We kind of discussed that in the presentation. We have a question about allergic reactions. So what I'll say is that the most common allergic reactions are actually to antibiotics. The chlorhexidine, the scrub that we clean people off with, is another thing that's common. Latex is more common. And then finally, our muscle relaxant is another thing that patients have allergic reactions to. The actual anesthesia medicines we administer, it's very rare that patients have allergic reactions to them. But when I talk to my patients ahead of time, I warn them that there is a risk of complications with allergic reactions. That can happen anytime. But I also tell our patients that the operating room is the safest place to have an allergic reaction because you literally have an IV and you have someone that can give you epinephrine and dose things perfectly to maintain your vital signs, to be able to intubate if needed, et cetera, et cetera. So it's actually a really safe place to have an allergic reaction like anaphylaxis. How do anesthesiologists communicate with surgeons? I love this question too, because I think it's so important to recognize how communication plays a vital role within the operating room, especially between the surgeons and the anesthesiologists. So I will say that different people have different strengths and weaknesses, things like that. I think that for me personally, I like to build a relationship with some of the surgeons I work with very frequently. So I work with certain surgeons that do really big cases, and I get to know them really well, to the point that if I have any concerns, so before this big case on Friday I did, I actually chatted with the surgeon the day before to ask him about how he was going to do the surgery so that I could prepare for the anesthesia part of it. So it just depends on the type of surgery. If it's a surgery is really straightforward, then I don't need to talk to them ahead of time. I know the type of anesthesia we're going to do because I've done this procedure many, many times. And if a patient is healthy, we don't really have to worry about a lot of variables or factors. But if the procedure is a very, very involved one, if it's a long case with a lot of blood loss or other potential complications, those are the times when we really have to have a conversation ahead of time to plan out how do we make sure that the patient is safe and that they actually go to the right place, like if they need an ICU or something like that. Has there been a situation where surgery was not safe for the patient, you had to stop it from happening? I love this question too. I actually recently did this for the first time. We call it delaying a case. We never cancel a case because technically they can get it done later. But I had a patient who previously came to us and had an allergic reaction, but it was not determined what medication they were allergic to. And so it was something where the patient needed to still be seen by an allergist to ensure that the medications we were going to administer for anesthesia for this next case were safe to administer. That being said, what was interesting, so I delayed that case, and then the patient came back after they saw the allergist. I took care of them. Unfortunately, they still had an allergic reaction, but we were prepared and we had everything we needed in order to manage that patient. So we definitely do delay cases. I had another patient that had a new onset of atrial fibrillation and was not stable. That's another time when automatically we will cancel a case as well, because everyone realizes that, you know, the surgeon wants to make sure their patients do well. And if a patient's coming to you in an irregular heart rhythm and it's new and it's not safe for them, then they're not going to proceed either. We talked kind of about my life as an anesthesiologist in a normal day-to-day. How many anesthesiologists per hospital and how often are you on call? So it depends on how big the hospital is, right? So my hospital, we employ over 100 plus anesthesiologists, and we have like close to 100 places where we provide anesthesia. So there's a lot of us. But in terms of how many anesthesiologists are in the hospital at any given time, overnight, we have like overnight being like after 11 p.m., we have 2 anesthesiologists, plus we have 4 residents, plus we have the ICU person that's readily available. We're also an anesthesiologist. So we have like close to like, I don't know, sometimes, oh, and we have an obstetric person upstairs as well. So we almost have close to 10 types of anesthesiologists available at any given time in a hospital at night. And so that's kind of a good way of looking at it. If it's a smaller hospital, they'll just have one for the whole day, or like for the whole overnight, or just a couple during the day, because there's some hospitals that are only like 3 or 4 operating rooms and that's all they need. So do different ages, sexes of people need different anesthesia? Yes, definitely different ages need different types of anesthesia. The approach we take is different for kids because their bodies are completely different as well. In terms of when you did biomedical engineering, was it easy to cover all the pre-med requirements? How else did it help in medical school and beyond? So for biomedical engineering, it covered all of my pre-med requirements. So it was kind of nice because I really didn't need to add anything else. In terms of how it helped me, what I'll say is I was very practical. I did a biomedical engineering degree because I was worried I wouldn't get into medical school and I needed a job. And I really just didn't want to have a bio major as my job. I wasn't really sure how I could use that degree. So I decided to get a practical degree. And I did actually work as an engineer because I got my first acceptance to medical school in May before starting medical school in August. So I thought, and my semester at University of Michigan ended in April. So I started working as an engineer in April thinking I'm not getting in, I'm not going to be able to go to medical school this year. And it allowed me to work as an engineer. So I thought that that was actually a really nice path. Luckily, I got into medical school and I quit my job after 2 months of being an engineer. And I'm so glad because engineering is not a good fit for my personality. I was so bored and did not enjoy it. As an anesthesiologist, does the majority of your time get spent in an operating room? Yes, yes. I'll just say it. There's a lot of different other areas we can provide anesthesia. So something to be aware of is like kids, if they need an MRI, they need anesthesia, like little kids, because they won't stay still in an MRI machine. So we actually get the pediatric anesthesiologist will get called in and they need sedation or anesthesia. Other places, like we will go to endoscopy. So when people need their colonoscopies or their upper GI scopes, EGDs, we can do anesthesia there. I frequently go to interventional radiology as well. We provide anesthesia down there. So there's a lot of different places we can be besides the operating room, but typically it's the operating room. What makes anesthesiology specialization in different fields different from one another? More specifically, how are they different from general anesthesiology? Great question. So a general anesthesiologist, for example, cannot work in an ICU as an intensivist like I have. So I got fellowship training because I wanted to be able to work in an ICU. And if you do not get that fellowship training, then you cannot do that job. And other things too, like generalists can't do obstetrics, they can do regular OR cases. They typically don't do cardiac anesthesia. So a lot of places require that you get specialization or certification in TE before you do open heart surgery at their center. So that's one area. There are some other smaller places that do not require it. And there's some older anesthesiologists that never got fellowship trained because they've been doing this for so many years that they've learned enough to be able to do these cases. But typically right now, you have to get training to do the majority of big open heart procedures. The other thing is pain medicine. So I would never want to go open a pain clinic and do pain procedures because I was not trained in that. So that's another area that a generalist is not going to do. They, an anesthesiologist that got trained in pain medicine can open a clinic and actually just do pain medications and management there too. So those are some of the examples of how things are a little different. PD anesthesiology too. I'd say that most anesthesiologists, generalists, are comfortable taking care of kids like down to even like 2 years of age. But when we're talking infants, that's something that generally pediatric anesthesiologists care for because their anesthetic plan can change very much so and can be very different from from adults, for example. Do I work with any PAs? That's a great question. So I actually do because we have PAs in ICU settings and we also have PAs in our post-anesthesia care unit in the recovery room after anesthesia called the PACU. So our PAs go around and actually keep an eye on patients to make sure that they're safe to leave the recovery room area and I can work with them. But PAs do not come into the operating room. In terms of the equivalent to a PA, with anesthesia, it's an anesthesia assistant or an AA. So that's a 2-year program and you can actually do anesthesia very similar to CRNAs, but you're supervised by an anesthesiologist. So that's the equivalent there. Do you work with other doctor specialties? How has COVID affected your work? So I'll tell you guys, I did fellowship during the peak of COVID. So I was an ICU fellow at the peak of COVID in Boston. It was heartbreaking. It was hard. I did a lot of extra shifts. It was devastating in a lot of ways, but I will say that it showed how resilient the human spirit is. And it just showed how great the people I work with are and how strong they are and how brave everyone was to come in to work every single day, not knowing if we would get ill and we would get COVID and die and be one of the patients. And it really changed a lot of things. I would say in the operating room, COVID has changed things because everyone needs to get tested now before they come to the operating room. If someone is positive, we talk about whether we need to delay their case or not. After someone has had COVID, their lungs typically are not as good as someone who's never had COVID. I mean, not everyone is like that. Some people have had pretty mild disease and we haven't seen too much of an issue there, but some people who've had more severe disease that come back to the operating room for procedures, we find that their anesthetic can be somewhat tougher because their lungs have been damaged by COVID. In terms of other doctor specialties, I mean, I work with most of the other specialties when I'm in the ICU because we call other specialties as consultants to help us manage some of our patients. In the operating room, it's typically only surgery that I would be working with. What are the side effects of anesthesia? Okay, well, if I'm if I'm consenting someone, what I'll say is that the most common side effects are nausea, vomiting, a sore throat, a bit of a hoarse voice. Sometimes patients can feel pretty uncomfortable from the way they're positioned on the bed while they're asleep. Other things that people don't think about is that when you are anesthetized, like under general anesthesia, we have to protect your eyes, because if you leave your eyes open while you're asleep, then they can dry out and cause you to have a corneal abrasion or a lot of pain. So there's a risk of damage to eyes. There's a risk of damage to teeth and lips, because as you saw in the photo, there's a metal blade that goes in when we intubate patients. So that is a risk, but it's not that high of a risk. I have had a patient who swallowed their bridge before after anesthesia because we had knocked out their bridge, but that's hence a risk that we talk about. And then I also talk about scarier things under anesthesia as a risk. So it's possible with surgery that patients could need blood, they could go into multi-organ failure, and I talk about potentially dying too, because that, even though patients can come in totally healthy, things can go wrong in surgery. And I always say it because I never want that to be something I don't mention to patients. Okay, were there any memorable cases, notably with other specialists? I'd say that, we work with every kind of surgeon. I just want to make that very clear. I mean, I personally don't do cardiac anesthesia because I didn't do that fellowship training in that, but I work with vascular surgeons, thoracic surgeons. I work with general surgeons. I work with radiologists. And so I work with a whole group of people. I'll say that my case on Friday was probably the most memorable case I've had, just because it was so much blood loss and it was a very complex case that we had to do. And it took a lot of energy and a lot of time. But it was a very rewarding one because the patient did very well. And so that was probably the most notable one. Do you only provide anesthesia for surgery and operations, or other special circumstances? So I kind of alluded to this. There's other places people get anesthesia, like kiddos getting imaging, or in interventional radiology, sometimes people need it. What are some cases that required uses of some complex sedation? So sedation is an interesting thing. What I'll say is that if a patient is getting a very non-invasive procedure, so for example, actually, patients can get a colonoscopy totally awake. Like, it's not the greatest thing in the world to have a camera up your butt, but it's also not going to kill you to have that happen. And anesthesia can kill you, because if you're really sick and we give you medications to take away the normal, the homeostasis of your body, you could die from that. So sometimes I have to have a conversation with patients to say, you have an anesthesiologist, but you're not getting anesthesia. You're just going to get relaxing medicine. So there's things that we have to consider and do whenever we assess a patient to decide what type of anesthesia to give. And sometimes the type of anesthesia is no anesthesia. That's the safest. Do you think anesthesiologists should be replaced by CRNAs? I love this question. Everyone always asks this question. I will say that every specialty in medicine has someone else trying to practice it. So, for example, optometrists are trying to do cataract surgery, so they're encroaching on ophthalmologists. PAs are opening derm clinics, NPs are opening derm clinics, NPs are opening various types of primary care clinics, and the oversight is not really there. CRNAs do have the ability to practice independently in a number of states in the US, so they don't need an anesthesiologist to oversee them. And what I'll say too is that at the end of the day, I don't think that CRNAs will replace anesthesiologists, because we bring in a higher level of care and knowledge base that's different from a CRNA's training. That being said, though, there are places where I think that will happen. You guys have probably seen in the news in Wisconsin, they replaced all their anesthesiologists with CRNAs, and that's a small hospital. And I'll tell you, I would never go to that hospital personally to get my surgical or anesthesia care, because I think it's important to have everyone in the team available. Plus, I will tell you that I think a care team is better than a single person always, even just like a single anesthesiologist, because two minds thinking about someone is better than one. Right? Two people means that you're going to ensure that if there's a mistake or an oversight, that someone else will catch it for you. But if you're by yourself, you find that you miss things because you just don't see it, because people are biased and people are imperfect. So I'm an advocate to say that more is better from this situation, and all you really care about is keeping someone safe under surgery. And finally, if you're going to get a huge complex surgery in a hospital like mine, you're going to want an anesthesiologist in that situation. So someone who's lost their blood volume 7 times typically managed by an anesthesiologist is helpful. And finally, I will say I did try to get an insurance plan by doing ICU because I don't foresee the ICU kicking out its doctors ever. I do think patients do expect that a physician is the one overseeing their family member or their care in the ICU. So do I think that all anesthesiologists will be taken over by CRNAs? No, I don't. But I also think that the role that we play will change. But I think that that's the case in every specialty because there's so many different medical providers that are practicing specialties in different ways. Finally, with technology developing, how do you see anesthesia changing in the next 10 years? That's really funny because a few years ago, we had a machine that was supposed to deliver anesthesia without, like a computer, to deliver anesthesia without an anesthesiologist for colonoscopies. It's supposed to be like the special propofol machine. And it administered propofol and it like talked to the patient and asked the patient to squeeze a little like ball or something. And if the patient stopped squeezing the ball, it stopped giving the propofol because that's the way to know that they're too sleepy and they're not safe to proceed at that point. The problem is the FDA rescinded approval of it, so it got nowhere. And so it's kind of interesting because there's in other countries, they use devices like this, that more automated type of ways to administer anesthesia. And ultimately a computer is less fallible than a human. Humans make more mistakes than a computer. However, a computer doesn't understand a lot of what's going on. If you ever look at any of these kind of AI things, how it's programmed, like garbage in, garbage out. Garbage in, garbage out, right? Like if you program it like crap because it doesn't understand what's going on, then it's never going to be able to figure out how to care for a patient. So that's the number one thing. Anytime we've used these, I use these support things through the computer to help me come up with a diagnosis, most of the time it's not that helpful because it doesn't integrate the big picture. At the end of the day, a human does a better job looking at the big picture. So I don't foresee it taking over things, but I do hope that there's going to be more support for managing the vital signs or support to figure out trends in our vital signs with big data and stuff like that. I would love to see us use all this data that we collect in the operating room to come up with trends for patients that we should anticipate that may have something bad happen, or we get an alarm saying like, oh, we're noticing that this has changed, consider X, Y, or Z thing. I think those are things that I foresee coming in the next 10 years, as well as potentially new medications and anesthetics that people are developing that are better than what we currently have. Okay, last chance for questions. My voice is tired. I hope this was helpful to you guys. But again, feel free to reach out to me all over social media. My email address is on the internet. I have a blog. Happy to answer questions. Thank you guys all for your great questions as well. Yeah.
Thank you so much. I think that's the last of our questions. And I truly learned so much from the shadowing session. It was phenomenally done. And thank you so much for coming to my medical message and presenting your, allowing us to shadow you today. Thank you.
Thanks for having me.
Of course. And also make sure all of you guys submit your Google Forms by 9:30.